My name is Laura Waldock. I'm a nurse practitioner. I'm actually privileged at Delnor and Kishwaukee hospitals. I work in palliative medicine, or otherwise known as palliative care. I just want to thank Living Well for giving me the opportunity to explain palliative medicine to everyone today, just because it can be not very well understood, and it can get kind of mixed up with hospice, and I'll explain to you the differences between the two. If you have any questions during the talk, you can post them in the comment section or ask me afterwards, and I will address them then. So this is, we have this hanging in the wall of our office. It looks like a MasterCard, but these are the hospital teams or the medical teams that want to know about your pets. We want to hear all about your pets. The infectious disease teams, because I want to know what's going on, trying to figure out why you're ill, and then the palliative care teams, because we are a patient-centered and relationship-based team. And yes, we know about our patients' pets. We know about our patients' families. We know about the medications that they're taking and onward. So just to explain real quickly, we have teams. Palliative medicine through Northwestern has teams throughout Northwestern facilities. For this talk, we are talking about the West region, which includes Central DuPage Hospital, Delnor, and Kishwaukee's Hospital. How we're set up is we see patients both inpatient and outpatient. We have new consults as inpatients. Sometimes those patients are turned into our outpatients as well. Our outpatient clinics are at CDH, in Warrenville at the Cancer Center, at the Delnor Medical Office Building. I have my office hours over at the Delnor Cancer Center. And then in Kishwaukee, the office hours are at the Cancer Center at Kishwaukee Hospital. We also offer telemed visits when appropriate. So there's a lot of confusion about the difference between palliative and hospice. Even people that work in the medical field get confused about them. Sometimes we'll get consults that say, or you will see something in the note chart that says, consider palliative/hospice for patient. One way to say it is all hospice is palliative care, but all palliative care is not hospice. If you look at this chart here, both palliative and hospice patients tend to be in late or end stage of a chronic, life-threatening, progressive disease that will ultimately take their lives. Both hospice and palliative teams focus on quality of life. So we talk about calling ourselves a quality of life team and managing symptoms in order to improve that quality of life. Both palliative and hospice teams have multidisciplinary teams. There are doctors as part of our teams, nurses, nurse practitioners, social worker, and the hospital chaplain as part of our teams as well. Some hospices also have other auxiliary staff such as music therapists. So with hospice, the medical care goes to the patients. So if a patient is at home, if they're in the hospital, if they're in a skilled care facility, they go to them. With the Northwestern model of palliative care, we see patients in the hospital, and then the patients come to us in our clinics. Palliative patients continue to undergo treatments for the disease. They still come back and forth to the hospital when they want to come back and forth. Hospice patients, again, they've stopped treatments for their disease, and the medical care comes to them. So they are focusing what we would call a comfort-focused approach. There's a little plot twist in this, though. Hospices can have palliative programs too. So there's two arms to hospices. They can have the hospice and then they can have the palliative. Northwestern does not own a hospice. So how that happens is they will have a nurse practitioner that will go see the patient maybe once a month, maybe twice a month. Typically, there's no additional services involved with that, like medical equipment or social worker or a chaplain. And then that nurse practitioner works with the patient's primary care team. So these are the typical type of patients that we see. We don't see just oncology patients, although I would say that probably 60 to 70% of our patients are oncology patients. Once again, our patients all have a late or end stage chronic, life-threatening progressive disease, and this disease will ultimately take their lives. So we see cancer patients that's treated with what's called palliative or extending life, making you feel better treatments versus curative. We see end-stage cardiac diseases, so like severe aortic stenosis, patients with severe heart failure that are not a candidate for further interventions, lung disease, such as end-stage COPD, pulmonary fibrosis. We've actually seen quite a few patients that have scarring from COVID-19, those type of patients. Neurological diseases, such as end-stage Parkinson's, dementia, strokes, ALS, infections. We've seen patients with infectious diseases, such as COVID-19. Sometimes patients will be bedbound and they will just have an infected wound and it's not responding to antibiotics and there are no other options for it. We've had patients like that. End-stage GI or gastrointestinal disease, such as cirrhosis, liver failure, and then end-stage renal disease. So these are patients typically who are undergoing dialysis, have started to weigh the quality of their life with going to dialysis. Dialysis doesn't benefit them much anymore. And so we see those type of patients as well. We'll have conversations with them. Let's see, palliative teams. So at Northwestern, like I said, our model is for inpatient. And so we round on the inpatients and then outpatients. Each provider at each different facility, CDH, Delnor, and Kishwaukee, each provider has their own clinic day when they see outpatients. The remaining days of the week, they're rounding at the hospital. They're seeing new consults. They're following up with patients that they've met previously. We also are on call 24 hours a day, 7 days a week. Somebody from the palliative team is on call. Our physicians and nurse practitioners, we all take turns being on call. So we can be reached outside of business hours for medical emergencies such as unmanaged pain. That's typically where we get the most phone calls, I would say, are unmanaged pain. Palliative teams are interdisciplinary. We are highly collaborative, not only with everybody in our own team, but throughout the hospital too. We work really closely with the hospitalists, with the oncology team. We work very closely with them. Actually, palliative is we're under that oncology umbrella. Every day we meet in the mornings for what we call huddle. And so it's the chaplain, it's the social worker, the nurse, physicians, APPs, nurse practitioners, and we talk about our whole roster of patients we have in the hospital. We talk about the patients that provider is seeing outpatient that day, because we try to look at the patients as a whole human, and everybody has those emotional pieces, for our social worker to give her input. Everybody has a spiritual side. It doesn't mean it's a religion, it's a spiritual side, and then the physical side too. So we try to look at the whole person. What we offer symptom management to improve quality of life. So I'll use the example for cancer patients. If somebody has cancer pain, we will help address that. Or if they have symptoms from the treatment from the disease. So if they're having a lot of symptoms that are affecting their quality of life from chemotherapy, then we help address that too, help make that better. We give support to the patient and to the family and their support systems. We have goals of care discussions. Those are just ongoing discussions that we have with patients and families about their wishes and their worries and how we can work with the rest of their healthcare team to make sure we are always following their wishes. Advanced directives. We can assist with advanced directives. We can explain them pretty well. With those, we call those the healthcare power of attorney and code status, and we'll talk about those in a bit. So once again, palliative medicine is the whole person approach. We are addressing the physical, emotional, and spiritual needs of our patients. And we are supportive. We tell our patients that our job is to walk beside them. That's our job. If there is a fork in the road for treatment options, we're available to discuss it with them. I'm huge on education. I always want to make sure everybody is fully educated All my patients are fully educated about their options so they can make the right decisions. And a lot of these are big decisions a lot of times that our patients are making. And I always tell them that no matter what decision they make, it's going to be the right decision. People worry if things are the right decision. If it's about them, so it's going to be the right decision. So in symptom management, more specifically, here's some pain. We do cancer pain a lot, disease-related pain. So we'll do the end-stage cancer-related pain. We don't do chronic pain, like lower back pain, somebody who's had spinal stenosis. We just don't have the bandwidth to do that. I know that that really affects people, and it does affect their quality of life. It's not a disease that's going to kill them, spinal stenosis. So we don't manage acute pain too. So if you have surgery, you have your appendix out, and you're having pain post-op, we don't do that. So you would notice that we would use what we would call a multimodal approaches to manage pain. Some people scoff at Tylenol. Actually, scheduled Tylenol along with an opioid can be very effective for pain. We try to figure out what type of pain it is, because pain arises from different places in the body, and where it arises from helps us figure out how we should treat it. There's something called neuropathic pain, and sometimes you can have neuropathy after chemotherapies too. And so we'll treat those differently than we would treat like an abdominal cancer pain. So we will also use something like repositioning, heat, a warm heating pad, ice packs. Sometimes we recommend the patient try complementary medicines like aromatherapy, massage, or acupuncture. Sometimes we'll prescribe physical therapy. That can be really helpful for pain too. We can help manage other symptoms too, along with the pain. If we're using opioids for it, we tend to constipate people. So we're pretty aggressive. If we're prescribing you an opioid, we're also talking about managing your bowels. So constipation, diarrhea, shortness of breath. Sometimes, somebody who has severe shortness of breath due to disease in the lungs, what can work for that is just a tiny bit of morphine, and that can really help ease that work of breathing and that feeling that you just can't catch your breath, that you're drowning. Just a touch of morphine. Appetite, nausea, fatigue, sleeping issues. And with any of these these are huge diagnoses, right? That you're getting. Somebody tells you have cancer, we would almost expect somebody to have some situational anxiety or depression, and we're going to address that too. We can do that through medications, but we also have the chaplain and social worker as part of our team as well, and that can assist with that as well. So what are goals of care? Goals of care are conversations that we have with patients that evolve. They're longitudinal. It's important that we establish care with a patient as soon as we can during their diagnosis. So they recognize us as part of their care team, and that the patients are comfortable with us, and they engage with us. So that we want to build a trusting relationship with you. When we understand the patient's goals, then we can work with the rest of the medical team to make sure that everything we're doing, all those interventions, are with the patient's goals in mind. So these conversations, these are 3 descriptor words about these conversations would be exploratory, conversational, and longitudinal. Like I said, these happen over a long period of time. I've had patients following me in palliative clinic for 4 years, more than 4 years. Conversational. We know where they're going on vacation. We know how many grandchildren they have. We know who their dogs are. We have some really good conversations along the way, and that's part of that trusting relationship too. Medical decisions. We help them with their medical goals. Once again, ensuring education. I always tell my patients, I want to make sure that you understand all of the options available so you can make the decision. I like to encourage autonomy. Patients are in charge, and sometimes it's hard, especially when we see patients in the hospital, it's hard for them to remember that they're lying there in an open gown attached to the bed with these tubes in their body, and Ultimately, they are in charge, though, and I think that it's important to empower patients so they know that. We talk about patients' medical goals, another round of chemo, or until you can't see the cancer on the scan. And there's also personal goals too that we will work with patients to try to help them to achieve. They want to go to their granddaughter's wedding. They want to go to their child's graduation. Those are important things that we want to know. If they're important to the patient, they're important to the palliative team. I hate reading things verbatim, but I love this definition of goals of care. And so unfortunately for you, I am going to read it to you. Goals of care are active. It's an active discussion about an individual's goals and preferences, specifically as they relate to end-of-life issues. And this is linked with reductions in hospital utilization and aggressiveness of care at the end of life, increased use of hospice services, decreased family conflict, a greater likelihood of receiving the care that they want, and dying in one's preferred place of death. Studies in adults have shown that patients with life-limiting illness want their clinicians to initiate these discussions about prognosis and goals of care. So if you're seeing a palliative provider, you can absolutely be having these conversations and not ever hear the phrase goals of care. It's when you come in and for the first 15 minutes, we talk about how your vacation was. Those are all goals of care wrapped up in that. So something else that we do, and especially I see this more so in the hospital, is we're kind of looked at as the experts for advanced directives. So an example of an advanced directive is a healthcare power of attorney or a medical power of attorney. And what this piece of paper says, and you can have this filled out at your doctor's office. If you see the palliative team, if you come to the hospital, your primary care doctor can do this. So it's who should make healthcare decisions for you if you can no longer make them yourself. It does not require a lawyer. It only requires a witness. You could actually you could do it at home, actually. It can't be a family member who's the witness. And it's for medical decisions only. Sometimes people think this is for financial as well. It's for medical only. This piece of paper is a piece of paper that's signed by you, that's signed by a witness. But we need to make this piece of paper alive. And the way you make that piece of paper alive is you make sure that those names that you have written down there about who you want to make those decisions for yourself, make sure that you have conversations with that person so they know what you want, because their job, that healthcare power of attorney's job, and I talked about this at the hospital earlier today, is to make sure that they are following your wishes. So you need to have those conversations with them and let them know what you want. For example, for my own healthcare power of attorney, I do have my paperwork done, and I've been married 35 years. I love my husband very much. My power of attorney is my son, who's a physician, because I think that he will understand and listen to my wishes more. I think my husband would probably do whatever he could to keep me alive. And he knows this too. So the most important part is talking to your loved one. So I can't say that enough. So if there's no healthcare power of attorney, and we probably see that, I would say at least 50% of the time in the hospital, at least, then we go by, there's an Illinois Surrogacy Act, and we go by what that act says. So if you're an adult that's married, then it's your spouse. If you have no spouse, if you're widowed, then it's your adult children, and it goes down from there. So this is a link for this. I don't think you can get it off of here, but if you want to screenshot this, then you can see the link. If you Google Illinois short form power of attorney healthcare form, then you can find it there. So another advanced directive would be a POLST form. It's POLST, and it's short for Provider Order for Life-Saving Treatment. And so this one is telling exactly what you want in terms of if your heart stops and if you stop breathing. This one does need to be signed by a provider, by a physician or nurse practitioner or PA, because this one is it's an order. It's actually a provider order, just like it says in the title. So this one exists. This is a state of Illinois form as well, and this is a legal form. You don't need to go to an attorney for it. You can fill it out in the office. But life support, this form exists because life support means something different to everyone. Intubation, some people say, I never want to be intubated. I never want to be on a ventilator. Feeding tubes, cardiac medicines known as pressors that help artificially keep the heart beating. Dialysis, there's different ways to support life that we offer. And some people feel very strongly that they don't want one or some of these. By law, we need to follow this. This is your voice. If your condition changes, this can easily be updated. I've seen people go through multiple posts. The most recent one supersedes the previous ones. So this is to honor your wishes and set limits on the care. You can also write in there specific care wishes. You can say, I want everything on there. You can say, do not resuscitate, DNR. You'll notice sometimes this is pink. These pieces of paper can be pink, they can be orange, they can be white. It doesn't matter. It doesn't matter what color they are. They're all the same thing. Illinois just recently updated this within the last year, and it's an easier, shorter form now. It's 1 page. Let's see, this can be, like I said, updated or revoked at any time. So somebody can say in the hospital, they're a do not resuscitate. They don't want to be resuscitated. But then as soon as and they'll wear a little purple band when you're in the hospital, and that's a DNR. And that simply means that if you stop beating, we're going to keep you comfortable and allow death to occur naturally. That's what that means. As soon as they step foot outside that hospital, that purple band is no good anymore. Then you need to have one of these forms in order to be a DNR or do not resuscitate. This form is always voluntary. We don't make somebody do this. Like I said, it's a state of Illinois form, and there's the website where you can get it. Why is there a refrigerator on here? There's a refrigerator on here because paramedics in Illinois know to look on or around the refrigerator for this form if they're called to a house. There's people who keep it in the refrigerator. There's people who keep it on the refrigerator in an envelope, in the freezer, right there. Often the paramedics will say, do you have any pieces of paper? Do you have anything around the refrigerator that talks about the patient's wishes when they come to the hospital? So this just talks about us being the quality of life team, how our team tries to look at things. Instead of she didn't, we like to say, it's not that she failed 6 rounds of chemotherapy. Chemotherapy failed her. She didn't progress, the disease progressed. She never complained about the side effects. She reported the side effects. She didn't become palliative. A lot of times we'll hear that. Well, they're palliative now. No, they can be everything else, but just have the palliative team on board. That just means she needed a new way of treating her whole being as she lived. How do I meet with palliative medicine or palliative care? Ask your oncologist or your primary care provider to place a palliative consult. And then our schedule, we vet them out, so just make sure there's not somebody with, I don't know, I can't think of anything. A non-progressive disease, with the flu. Maybe you feel like dying because you have the flu, but you're not palliative. So our scheduler calls you then to make an appointment.